Welcome to a new episode of Aimed Revolution, where we explore the most fascinating intersections between artificial intelligence and medicine. I'm your host, and today we're going to dive into an innovative study recently published in New England Journal of Medicine AI that is transforming one of the most critical processes in emergency departments: triage. What if AI could help better identify critical patients and reduce wait times in emergency rooms? Dr. Andrew Taylor and his team have published fascinating results that could revolutionize how we manage emergency services. Ready to discover how AI is improving emergency care? The study titled Impact of Artificial Intelligence-Based Triage Decision Support on Emergency Department Care, led by Dr. Taylor from Yale School of Medicine, addresses one of the most persistent challenges in emergency medicine: effective patient triage. All of us working in medicine know that triage is the critical first step for more than 145 million patients visiting emergency departments in the United States each year. The most widely used system, the Emergency Severity Index, ESI, although widely adopted, has significant limitations. It's subjective, creates variations in practice, and can lead to biases in care. The researchers implemented an AI-based clinical decision support (CDS) system in 3 distinct emergency departments with varied demographic and operational characteristics. The machine learning algorithm analyzed routine data collected during triage, including patient demographics, arrival mode, vital signs, chief complaint, and active medical problems. The methodology was robust. They evaluated the impact by analyzing more than 174,000 emergency visits, comparing 180 days pre-implementation versus post-implementation. What's really sophisticated about this system is how it translated the probabilities of critical outcomes into triage-level recommendations from 1 to 5, following the ESI structure already familiar to staff. Additionally, it provided explanations using SHAP values transformed into natural language, making the system more interpretable for healthcare professionals. The results of this study are truly impressive. Let's look at the key findings. Significant triage redistribution. With AI, there was a 48.2% increase in patients classified as low acuity, levels 4 to 5, an 18.7% decrease in medium acuity patients, level 3, and an 8.8% decrease in high acuity patients, levels 1 to 2. Improvement in identifying critical cases, sensitivity for identifying patients needing critical care increased from 78.8% to 83.1%. Substantial improvements in patient flow. Times from arrival to initial care location were reduced by 33%. Time to emergency department disposition by 4.2%, and time to emergency department departure by 6.1%. The most dramatic results were observed in the most severely ill patients. For patients requiring critical care or emergency surgery, there was a reduction in time from arrival to emergency department departure of 58 minutes, 11.9%, in the median, with an average difference of 156 minutes, 21.5%. This finding is particularly important because these patients benefit most from rapid intervention, considering the well-established concept of the golden hour in emergency medicine. A secondary but potentially significant finding was the change in the racial distribution of patients among different triage levels. The authors noted a 10.9% decrease in Black patients within the low acuity group, with a corresponding increase in white patients of 8.1%. Although the study did not delve deeply into this aspect, it raises important questions about the role AI could play in mitigating implicit biases in clinical decision-making. What I find particularly revealing is the interaction between human judgment and AI. The study found significant variability in the level of agreement between nurses and AI, with rates ranging from 57.2% to 79.1%. Nurses with high agreement with AI perform better than AI alone, while those with low agreement perform worse. This variability raises important questions about implementation. How should staff be trained to optimally interact with these systems? How can we promote an appropriate level of trust, avoiding both unjustified distrust and overconfidence? What support structures are needed to facilitate the integration of AI into clinical workflows? A distinctive feature of this AI system is its ability to provide personalized explanations for its recommendations. The generated explanations use SHAP values transformed into phrases like increased risk of critical care due to moderate tachycardia, severe tachypnea, and history of hypertension. This transparency allows nurses to evaluate the logic behind the recommendation, facilitates continuous learning, builds confidence in the system, and provides an auditable record for retrospective review. This underscores something we always emphasize on Aimed Revolution. AI is not here to replace medical professionals, but to enhance their clinical judgment. The synergy between humans and technology can lead to superior outcomes. The redistribution of patients among triage levels has substantial implications for resource management. The increase in low acuity patients allows for more efficient routing to fast-track care areas, freeing up resources for more severe patients. The decrease in medium acuity patients reduces overcategorization to level 3, a known problem with ESI that can represent up to 70% of all patients in some settings. The slight decrease in high acuity patients suggests the system might be reducing over-triage while maintaining or improving identification of truly critical patients. These changes occurred despite an 8.1% increase in patient volume during the study period, suggesting that AI systems can help manage increasing patient loads without requiring additional staff or facility expansion. Although the results are promising, we must acknowledge the study's limitations. The pre-post design, despite statistical adjustments, is susceptible to temporal confounding factors. All emergency departments belong to the same health system in Connecticut, which may limit generalizability. There's also the possibility of contamination, as nurses who worked across multiple sites might have been exposed to the AI system during different periods of the study. Finally, the study focused on short-term outcomes without evaluating the long-term impact on patient outcomes. Future research should consider cluster randomized controlled trials, implementation in more diverse health systems, evaluation of long-term clinical outcomes, cost-effectiveness analysis, and deeper study of the impact on disparities in care. This study sits within a broader trend toward augmentative AI in medicine, where technology complements clinical judgment rather than replacing it. It's particularly notable that it demonstrates benefits in a high-pressure environment like the emergency department, where decisions must be made quickly with limited information. The success of this implementation also highlights the importance of designing AI systems that align with existing workflows and provide immediate and visible value to clinicians rather than creating additional burdens. This study by Dr. Taylor and his team perfectly illustrates how artificial intelligence can improve a fundamental clinical process. We're not talking about theoretical or futuristic AI, but systems that work today in real hospital environments, improving patient care and operational efficiency. For our listeners who are medical professionals, consider how similar tools could be integrated into your own clinical settings. For those interested in AI and medicine, this is an excellent example of a practical application with measurable results. Before we finish, I'd like to ask you this question. In what other critical clinical processes do you think AI could have a similar impact to what we see in triage? Share your thoughts in the comments. Until then, keep innovating at the intersection of AI and medicine. I'm your host at Aimed Revolution. Thank you for listening.